I'm Dr. Sauer. I'm part of the Palliative Care program here at Methodist, and we're going to talk today a little bit about palliative medicine in general. I'm going to go through it pretty quickly because a lot of you, I think, have heard parts of this talk, and I really want to have time for us to talk about how palliative care and surgery can work better together. So let's, without further ado, I'd like to start off by explaining more specifically what hospice is. A lot of people are aware of hospice, but it's easier to compare what palliative care is if we have a firm grasp of what we're talking about end-of-life care and hospice. So hospice, many people think of it as a place. I'm going to go to the hospice, or an organization like VNA Hospice. It's a philosophy of care. Some people think, well, are you in the mindset of hospice? But in this country, I'm going to look at the social workers. Hospice is a governmental program known as the Medicare Hospice Benefit. Medicare runs everything, I would argue, in our healthcare system. Insurance companies look at what Medicare does, and then they often follow in line. So because people don't have Medicare, they have private insurance, they probably have a hospice benefit that mirrors or looks very similar to Medicare. So we're going to talk about what Medicare's hospice benefit is about. A little history lesson. I'm going to kind of tongue-in-cheek part of this to make it more fun. But the Greeks and Romans cared for their loved ones that were dying in temples. And people will say, well, that was the first instance of end-of-life care or hospice. But Dame Cicely Saunders, in the late 60s, started St. Christopher's Hospice in the south of London. She was a physician, a nurse, and a social worker. And she thought that end-of-life care and meeting patients' needs was poorly done in the medical system. She thought it could be done better. So she started the hospice movement, the modern hospice movement. In the early 70s, nurses in this country saw what she was doing and said, what a great movement. And they started a grassroots hospice movement here in this country. It was all volunteer. The nurse did her 12-hour shift at the hospital, went home, knocked on the neighbor's door and said, I hear your dad's dying of lung cancer. I'm a nurse, I live right next door. If you need anything, you call me for help. So nurses kind of banded together in a grassroots movement to help people stay at home and meet their needs at the end of life. In 1982, Congress. Did you hear my tone of, okay. Congress got involved. Congress got involved and made things just a holy mess. Back here, you didn't have to qualify. If your family had needs at the end of life, no matter what, your community would help you. And Congress said, we should help pay for this. And while that is a great sentiment, they don't pay enough, and they had to put all sorts of rules on hospice. So they said, they sat in their little chambers in their leather chairs, and they said, this might cost a lot. Do you want to do it for people for 5 years? And they said, oh, that's way too long. But they knew that more than a few days was going to be needed for help. So they sort of arbitrarily came up with 6 months as the time you could be on hospice. Because doctors, they thought, were so great at giving a prognosis. I'm going to look at the doctors. We're so great at giving a prognosis. I would argue that in 1982, hospice shot itself in the foot. We are terrible, all of us, at giving an accurate prognosis. I'm going to see which one gives me the funniest smile because then they think they're awesome at it. We are all relatively terrible at giving a prognosis. Arguably, cancer is the best thing that we do. Heart disease, COPD, we don't know when the end is coming. So rather than base the system off of patients who want and need the support, we base it off their prognosis. A lot of people think hospice is giving up. I really think that hospice helps the medical team not abandon patients. I think a lot of patients continue to do things because they think if they say to their oncologist, I don't think I want treatment any longer, their oncologist is going to say, all right, go home, good luck. This is a way that our medical system and medical team stays engaged in helping the patient and family regardless of what their decision is for treatment. It's aggressive symptom management. When I first got back into town, the first week, I wrote orders in the ICU at Bergen to help somebody with IV lidocaine. And with IV lidocaine, and 5 minutes after I wrote the orders, the head of pharmacy and the head of nursing called me because we were doing things that they'd never seen done to try to help somebody be more comfortable. So we don't just hold hands and sing kumbaya around patients. We do aggressive symptom management. It's holistic care, body, mind, and spirit, and the goal of care is a dignified and peaceful death. Most people say, I want a dignified and peaceful death when my time comes. That's our goal. So other rules, what can and can't we do on hospice? Medicare has very few rules, but what Medicare says is you get $100 a day to care for this patient, to pay your staff, to pay for meds, to pay for equipment, and the meds alone. So there are no rules. Medicare says you can do whatever you want. If Warren Buffett gave me $2 billion to run a hospice here, we would do all sorts of stuff for people. But hospices are businesses. So do you have to be a DNR? No. There are some people who can't make that decision. They come on hospice and we work with them for weeks and months till the family sees the writing on the wall, and then they're willing to make that call. But you don't have to be DNR. Can you get antibiotics? Sure. You're 30-year-old with lung cancer, your kid graduates from junior high in 2 weeks, and you have a fever and a cough. Would I give you antibiotics to try to get you to his graduation? Absolutely. Would I do a whole bunch of labs and a whole bunch of x-rays and all the? Generally not. But the problem is if you are a 90-year-old patient with dementia and every time you sneeze or every time your urine is a little yellow, your family demands antibiotics, we can't always do that. Medicare says that most people with dementia die of infections. And if every time you think you have an infection, we treat you, Medicare says you're sort of prolonging their life. They're living longer than 6 months. You can't do all this treatment and get support for end-of-life care. We do feeding tubes. We can do radiation and chemotherapy if we can come up with arrangements to make it affordable. If the chemotherapy agent is $1 a day, let's have at it. If it's $1,000 a day, the hospice says, we'll go bankrupt in 2 days. Transfusions. In my fellowship at San Diego Hospice, the head doctor wanted to offer transfusions. She was convinced that people were postponing hospice because they wanted transfusions. And she said, we need to offer these. And her board said, we're going to go bankrupt. She said, I don't think so. So they started to offer transfusions where appropriate. And what they found is a lot of people want the control of being able to talk about a transfusion, but when the time comes, they don't actually want it. They don't like us taking things off the table and minimizing their care. But when we get to the point where we have a realistic conversation about their transfusion, they actually do very few of them. Prognosis. Goals mean everything. If I have 2 dementia patients, one, the family says, Dad said when he didn't recognize me that he would not want anything prolonged. We want to focus on his comfort and quality of life. We're not going to treat whatever the bump in the road comes that's going to take his life. Versus the family who wants everything done no matter what. They are the exact same dementia patient with a very different likely prognosis because of their goals. We have an amazing medical system, but are we really listening to our patients? We can do a lot of things, but how often do we stop and sit down and make sure that what we're doing is what the patient really wants? And then cancer prognosis is the thing we do best, and other things are worse. So generally, patients with cancer find out they have a little problem, but they're pretty functional and doing pretty well when they have their issue. And then over time, whether it's months or years or longer, they have this gradual decline till their death. Compared to heart disease and COPD, we have these huge fluctuations. On deathbed in the ICU, amazingly gets back almost to where they were. So these patients and families, we go in there and say, we want to prepare, we think we're getting close to the end of your dad's life, and they say, we've been there 2 times this year. Why do you guys think now is the time? Our great ICU work in medicine actually makes this a lot harder for families sometimes. Discussing hospice, it's the elephant in the room. Families and staff are both waiting. If you survey families, they say when the medical team feels it's appropriate to bring up hospice, they will. If you ask the doctors when surveyed will say when the family is ready for hospice, they'll bring it up. So I think there are times when there's a loved one, the doctor and the family, and both sides are looking at each other going, wow, they just don't get it. We think the family doesn't get it. They think we don't get it. It can be really, really challenging to have that conversation. It's never easy to talk about, but it's about communication. Whenever I talk to residents, they're always afraid to say the H word. How do I go in and say the H word to the family? I rarely go in saying the H word to the family. I go in and ask them how things are going, what their goals are, what they would really want. And if I feel like hospice is an appropriate way to manage the care, I'll say, you know what? What I've heard you say is you're getting tired of therapy, you really want to focus on your quality of life, and you'd like some more support for your family. And they're like, yeah, that's what I'm saying. And I say, can we talk a little bit about a program that's scary for some people? And they go, what could be scary about exactly what I want? And I say, it's a program called hospice. And then you'll see their reaction. They'll either go, and you know that you've touched a nerve and we need to have a conversation, or they go, oh, my grandma had hospice. You think now is the time that we start talking about this? So we need to communicate, find out what our patients need and want, and then bring up what their options are, as opposed to feeling this pressure like we have to push them onto hospice. So that's hospice. Quick questions about hospice. Anybody have? And by quick, I mean I was 20 minutes late, so we got to go really quick. So let's compare that. So again, hospice is a governmental program to pay for support at the end of life. It is put into a little box of less than 6 months by Medicare, horribly inappropriately, I would say. So doctors and nurses that were doing this noticed something. The vast majority of people we were caring for and helping were on hospice for days to a week. People come in and out of the hospital, and then all of a sudden, on one hospitalization, everybody goes, oh my goodness, they're dying. Quick, get them on hospice. And we weren't really helping families and supporting them for long periods of time leading up to the end of their life. So doctors that did this said, rather than call it hospice and take benefit of that, I'm going to say that I'm doing palliative medicine, and so there is no prognosis that I can care for people. In the time of Laura Ingalls Wilder, Little House on the Prairie, any fans? Okay, so there was one general doctor in their town. Then there was some more general doctors in Sleepy Eye, the next biggest town. Who's impressed I know that? Okay. So doctors do things. So in Sleepy Eye, there was probably 5 doctors. And one of them said, I think a lot of people are dying from head and neck cancer problems. And they said, can you guys send all your head and neck cancer patients to me, and I'm going to study them and treat them and become an expert in them. And so that doctor did that for 20 years, and then our medical system recognized that as a new specialty. So doctors do things for years on their own, kind of, and then we recognize it. So at the end of my fellowship in July 2006, we were officially recognized by our medical system as a new medical subspecialty. And it's care that aims to relieve suffering and improve quality of life with all other treatments. The biggest beef with hospice is I have to give up things. Palliative care says, you don't have to give up anything. I'm here to help you no matter where you are in the course of your illness and no matter what your needs are. I primarily break it down to families in 2 ways. We help with symptom management, giving you the best quality of life and the comfort that you want. We also help with communicating breaking bad news, education about end-of-life care, helping with challenging decisions. Every day, I meet patients in the ICU who are paralyzed by the situation and the choices they have in front of them. And I metaphorically hold their hand and walk them through what we need to do. And I think a lot of families, our medical system, we went from a paternalistic system. My grandparents would just do whatever the doctor said because there was God and then their doctor. Now we've swung to patients are consumers that we have to keep happy and they have to have choice. And we've swung too far over here where we just dump all this on their plate and say, you make a decision. And I think for a lot of patients and families, that's a lot of pressure. And they are looking for somebody to help guide them more in a shared decision-making model. And so that's kind of what we do and how we can help. There's the curative model of care, which we all learned in medical school. So let's say that I found out that I had cancer today. I had a cough. I went in and saw them. They did a scan, and I got a lesion in my lung. I have a diagnosis, and I have a bunch of treatment. Oncologists, everyone's going to say we have a bunch of treatment available. Now it's Tuesday night. I've been treated for 8 months, getting thinner. Things aren't going really well. And I go in to find out what the next greatest thing is going to be. And my oncologist has to tell me that that was the last reasonable attempt to help cure me. We've been going full steam, what is this conversation like to have for the doc? Super hard. What's it like for my family now to hear? Really, really hard. That is a huge, huge conversation to have. If we compare that with the palliative model of care, at diagnosis, there's all this to do, and I'm having a little cough, very little symptoms. Why can't my oncology team with the palliative care team manage my care? These people are focused on cure and prolonging my life as long as I can. This team focused on communication and quality, working together. When we reach this point, if everyone's doing their job, it's an easier transition for patients. Why do we need it? I think we all know why we need it. We have an aging population. People are living longer with more chronic illnesses. The number of people, as we age, the numbers are exploding. Are the number of doctors in nursing homes and surgeons exploding? It's not. We have to be able to care for more sick people with not a lot more resources, unfortunately. The baby boomers are demanding more. My grandparents, when they got into their 90s and their family told them they had to go to a nursing home, they went, okay. The baby boomers is the greatest generation, but they've always adapted to the situation. Wars, whatever this country needed, they adapted and did, and they didn't throw much of a fuss. That's the greatest generation. That's the greatest generation. The baby boomers, my parents, have never liked the system, have bucked it every step of the way. I moved away from Minneapolis so that my sister would have to deal with telling them they had to go to a nursing home. And I would be the great son in Omaha who didn't have any part of this. So baby boomers, so we have this group of sicker people that are going to be demanding a lot more. They are not going to be happy with their options. Care is expensive at the end of life. And this is one that care is expensive at the end of life. And I would say that if we surveyed Americans and they say, I want 3 ICU stays in the last year of my life, make this happen, I would call Mr. Trump and say we need more funding for health care because people want to be in the ICU the last year of their life. The problem is when we survey people, nobody wants to be in the ICU in the last year of their life. It's super expensive care that we offer people in the last year of their life, and I would argue it's not what most people want. We've got to find a way to meet people, do the care that they want on their terms, and not spend all this money on care people don't want. We have wonderful care in this country. We've got to find a way to use it appropriately where it's needed. And then poor symptom control, there was a study done in the mid-90s to see how we did with end-of-life care, and one of the findings was we do a super poor job on managing symptoms. They surveyed people after being in the hospital for a week about their pain control, and it was terrible. If they were in the ER, I would say, okay, the person isn't taking their medicines like we told them. They're responsible for their pain. Let us fix it. But this was people that were surveyed after being a week in the hospital with us in control of their meds, and they still had really poor symptom management. Barriers, the public knowing about what palliative care is, the tide is turning. I started the program at the Med Center 8 years ago, and we agreed that I wouldn't be there on the weekends because I was by myself, and we said, we'll just have you there for the week, the first year, and we'll see how things go. So I was going to start this one Monday. The Saturday before that Monday, I get a call. There's a family member up here from Seattle, and she is appalled, number one, that we don't have palliative care here on the weekends, and that you can't come up here right now. So the tide is turning. My mother-in-law sends me clippings about palliative care from news things about every week. So the tide is turning. Medical staff, the familiarity is growing. People are getting more comfortable with our service and seeing how we can help. We often help with severe symptoms or severe end-of-life care. People are right at the end of life, and the attending says, hey, let's see what they can do. We are hopefully doing good care at the end of life and helping physicians, and they're going to start to say, what if they saw the person 2 weeks before that end of life care? Would that have been helpful? We're going to slowly see our care move earlier. Hospital systems, payment structures. 5 years ago, I was saying we need to be prepared for outpatient palliative care and meeting patients' needs. Once MedStaff gets familiar with us and patients demand us, we need to be able to ramp up our support and our help and our care. The problem is 5 years ago, we were still primarily in a fee-for-service world. The hospital basically, without saying it, was saying, why am I trying to keep people out of the hospital? People come in the hospital, that's what we do for a living. Now that we've got the CHF on a bundle and we're getting paid differently for overall health and care, all of a sudden the CHF team wants to meet with me urgently. How can you keep these people out of the hospital? So we're starting to plan and try to build more support outpatient-wise. And then here at Methodist, Jackie and the team has done a great job of getting some clinic time started over in the oncology center. That has been great. It's only going to blossom and grow. CHI, the Med Center, everybody has tried clinics over the last 7 years, and they have started for a few months and then failed. It started and failed because there wasn't enough support. These guys have started a wonderful clinic program. It's slowly starting to grow, and I think it's going to continue to. So kudos, they're doing a great job. And then payers are slowly recognizing the benefits. So misconceptions. It's just like hospice, it's only end-of-life care. I think that you understand now that that's not really the case. They're not ready for palliative care. I had a patient this week diagnosed with metastatic melanoma who came in. I helped his wife's family with her parents years ago, and he was just found out he has these mets, comes in with a problem, and she wanted to see us. I went in and we talked. He had surgery. He's doing great. He's got a lot of treatment ahead of him. But she wanted to see us so we could be introduced to him so he would know how we're going to help going forward. I would argue it's never too early for palliative care. We're going to talk about a study in a minute from about 10 years ago. But when I first started, I said, you wait. There's going to be a time, 5, 10 years from when I started, where cancer centers are going to be approaching palliative care and saying, no longer are we scared of you. We want you inside our doors helping our patients. That graph I showed you with the palliative care model, I would say at diagnosis, there was a lot of treatment, but the point of the triangle still touched diagnosis. Some cancer centers, when you go in for your first appointment, you meet all sorts of people. My radiation oncologist, my oncologist, my surgeon, my social worker, my therapist. I think you're going to meet your palliative care person on the team because people are going to want you to be aware of it from the very beginning. People think that palliative care has an agenda. Well, they're just going to come in here and do end-of-life care. They're just going to come in here and convince my patient to stop treatment, or they're going to kibosh all the plans that I think are appropriate. Palliative care has no agenda. Palliative care needs to reach out to the primaries, find out how you perceive we can help. Then we reach out to the family and we kind of see where they are, and we sort of help navigate some of this stuff. But we don't have an agenda to stop things. I've talked people into surgery, patients who were sort of against it, thinking, is it going to be worth it? After talking to the surgeon and the family, I said, I know that you're thinking against the surgery, but I want to know why, because I think it's a great idea. So we don't have an agenda. People are afraid we'll take over and cut them out. That's also not true. We're here to support your care, not take over for your care. And then managing pain long term. Our country has a problem with pain management. I don't know if you've heard. Pain management is very hard, and everyone touts that we need these comprehensive clinics around the country to help. But they're not paid very well, and no one really has them. It's very, very frustrating. So will we manage pain long term? As our resources build and our clinic gets more established, we hope to be able to help manage symptoms long term for people that are appropriate. If you are a head and neck cancer patient that we're helping with your pain, we hope to be able to help those patients. If you are a 30-year-old with chronic low back pain that's looking for a new pain doctor, we're not interested in that. We're not chronic pain people. We are more targeted towards cancer pain and more generally end-of-life pain issues. So we help prepare families for the future, relieve fear of the unknown. I had a patient with breast cancer who wanted to meet with me. I went to her house. We met for 2 hours. She said, I have breast cancer. I have surgery planned next week. I have all this treatment. I'm going to live a long time. But she said, I'm a control freak, and I have some questions about end of life that I need answered. So we just talked for 2 hours, and you could watch her anxiety just melt away during our visit because she felt like she had some control and things weren't unknown anymore. Again, we shouldn't have an agenda. So there was a Tamil article in the New England Journal of Medicine about 10 years ago. They did a study where patients came into a cancer center and they did the usual traditional care one arm. The second arm, they added a monthly palliative care visit. And they wanted to see, what they're hoping to see is better symptom management and hopefully better use of resources. Are people getting to hospice sooner if palliative care is involved? What happens? And what they found was symptom management was better, quality of life and utilization of resources was better, and people lived about 3 months longer. Not only did palliative care not shorten people's lifespan or get them to hospice too soon, people lived longer with palliative care support. Managing symptoms, having people feel better, allows them to tolerate more treatment. So that article, palliative care doctors around the country went running through their hospitals, waving this article in the air, throwing it at anybody they thought would read it. So again, we don't shorten things, we actually hopefully are helpful. So this is the patients we're looking for. Challenging symptoms, a lot of hospitalizations, challenging dynamics, complicated discharge situation, education, and family meetings. My wife's friend, her dad had a stroke. It was in the ICU, and she said, "Oh, are you going to have to go see him? Are you going to have to go see my friend's dad?" And I said, "No, we don't see every person at end of life. We help with, they didn't have challenging family dynamics. He didn't have any symptoms. The family got education from their primary team. So we don't see everybody." I used to do family medicine, and I hated ortho. So whenever anyone came in with an ortho problem, I got the x-ray, and then I made them an appointment down the hall. I hated orthopedic stuff. Every specialty likes to have someone they can go to for big issues. I managed hypertension as a family medicine doctor, but there's a certain percentage of people that I had to send to nephrology to get help because I couldn't get their blood pressure managed. We don't want to see every patient. We want to see the patients where you could use our support. And again, perhaps someday that'll be that we're introduced to every patient when they come into the clinic, but we may not be that involved based on how their care goes. So what is a palliative care program? It used to be really poorly defined. When I first got back to Omaha, bringing, I would argue, the first real program to Omaha, the Center to Advance Palliative Care had pins in this map online where there was palliative care programs. And there was a pin in Omaha. And I thought, well, that is really bizarre. I wonder what that is. And they were pinning a program in Omaha because when patients were dying, they would roll a comfort cart that had a radio and some nice fleece blankets. And they would put that in the patient's room so the family would be more comfortable. And that was their palliative care program. So it was very loosely defined on what you had. So whenever you read things about palliative care, always take with a grain of salt that it's new enough that the standards and what is expected are very, very different. Home care agencies, if you called any home care agency in this town and said, "I'm interested in palliative care," they would say, "Great, we have it." And then if you said, "What exactly do you do?" they would say, "Hold on, I'll get you forwarded to Linda. She can explain it to you." And then Linda would say, "Let me get you Susie." And then Susie would say, "Let me get you Diane." And then Diane would never answer her phone. It's sort of the sexy thing in medicine to say you have palliative care, but a lot of people, one place I went to and toured, we were going through, like, these are our home care nurses, and they said, "Here's our palliative care nurses." And I literally stopped, and I went, "Huh, so why are they the palliative care nurses?" They said, "Well, they went to a 1-hour pain lecture." I said, "Well, who pays for that?" I said, "What do you mean?" I said, "Well, Medicare doesn't pay for palliative care, so who pays for that?" They said, "Well, home care." So they're on the home care benefit. They're on the home care benefit. That's what Medicare is paying for. But because their nurses had an hour of pain control training, they're calling them palliative home care so that they can have that on their logo because everybody wants to have it. My point being, you always got to try to figure out what truly are you getting for palliative care. And the Joint Commission has launched an accreditation for it. So home care, you have to be homebound, have a skilled need, and it's often time limited. Someone leaves the hospital, they need a little bit of extra help at home with therapy or IV meds, they can get home care. The hospice benefit, we talked about, it has to be very end-of-life care. There is no palliative benefit. So one of the resource issues that we have is I have to go to Methodist administration and say, "Hey, we want to grow our palliative care team, and we want to do more outpatient work." And they say, "Well, where's the funding for this?" Well, there's funding for some things, but there's not funding for this. So I've got to convince them that our care and our support and hopefully our shorter length of stays and our keeping people out of the hospital are a financial benefit that they understand and will fund us for. So that's why palliative care programs start. People are really interested, and then the growth takes longer than I would like because I have to go to the accountants and try to convince them to give us more money to do better care. But it's a hard road. So 15 years ago when I was looking at fellowships, all the outpatient clinics in the fellowship programs were closing their doors. They started their inpatient program, they started clinics because it felt like the right thing to do, and the overhead squashed them. Eventually, after a year or two, the administration said, wait, you're losing money every year. Why do we have you open? And the palliative care program said, because it's the right thing to do, we're doing good care, and they said, sorry. So they were all closing. But now that medical reform is changing the payment structure, there's this renewed interest. So 15 years ago, they were all closing. No one really had them for a decade. And now people are saying, wait a minute, that cost savings, that caring for people and keeping them out of the hospital is something we need to be doing, and palliative care is going to be one of the things that we can do to help with that. A number of years ago, the VNA got some philanthropists to give us money to trial a program. It had some successes, and some things went not so well. We are trying to figure out how to do outpatient palliative care better. You're going to hear programs pop up. There were some for-profit hospice programs that were doing palliative care in nursing homes. They hired nurse practitioners to do it, and they were all rah, 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 rah. And then a year later, they shut the doors because of financial reasons. Again, it has been a bumpy road getting this started here, but I think all the stars are aligning with medical reform, our program growing. I really think in the next, hopefully months to next year or two, we're going to see some real movement to do outpatient care better. So to review, hospice is for people at the end of life, but palliative care is just a small, or excuse me, hospice is just a small part of what palliative care can do, and we help with those things. This is a patient that I think illustrates really well how palliative care can work. I saw a 28-year-old woman with cancer who was very resistant to using any kind of pain medications, and she was missing work and really suffering. Her oncologist called me and said, hey, I know you're fairly new to town. Is this somebody that you think you could help? I went to her home, met with her and her husband, convinced them to work with me and work on her pain control. I called 2 days later, and she was heading back to work. Her pain was controlled. She was doing great. She did great for a number of months, ended up in the hospital in a crisis. I saw her in the hospital, adjusted her pain medicines, and the oncologist was really concerned because the patient had some alternative views on how she wanted to treat her cancer, and the oncologist was really struggling with that. So I went in, I helped negotiate with the patient and her family what they were understanding. I helped kind of the oncologist and the family make a decision on where to go from here. She did well for a while again, and then ultimately went out of town for some treatment and came back with some with a spinal cord compression and some real serious issues. I met with them, and we started talking about hospice and end-of-life care. We transitioned her to hospice, and I worked with the family through feeding tube questions and through a bunch of questions until the end of her life. So that's someone that we met earlier in her illness for symptoms and introduced our service, built rapport over time, and then we're able to help the oncology team transition her when it became appropriate to end-of-life care. So, questions?
Thanks, Bob.
And sorry again.
A couple of questions. So, number one is like when we start getting the bundled payment model, you know, like we're gonna get a cancer patient and we're gonna have this bundled payment to take care of them. They need chemo, they need radiation, they need surgery. How is palliative? What's going to be the incentive? Because I mean, I do believe it's important, but you know, now they're kind of. I think that could hurt it again, whether it's going to be de-intensifying palliative care.
So my understanding of these like CHF bundles and all these bundles is somebody comes in with this, and we get a lumped care for them from here forward. And I think we're going to realize, like all diseases and illnesses, people end up back in the ER for issues that I would argue a lot of times could have been managed without coming to the ER. And a lot of these people end up in the ER and ultimately admitted. Part of what we're trying to do, what I'm trying to build is more than just some clinic time to sort of see them, is I'd like to build a home care piece of this. So if it's 2 in the morning, we have a place these patients can call to kind of screen, what's going on. And they say, well, I'm having a lot of pain. Well, come into the ER and maybe get admitted. That's an expensive path to that solution. Perhaps a visit from a nurse at 2 in the morning with some guidance from the palliative care team could get the pain under control, and they could follow up in our clinic or your clinic or something. We're there to support what overall patients' care needs are. And I think one of the gaps is, if I have CHF and I'm at home, they have monitors now that they put into the home to try to catch the weight gain before it gets enough to get people to the ER. My parents have been more ill over the last year, and my parents are not medically savvy. And when they have a problem, there were mornings I'd wake up like, oh, Mom took Dad to the hospital last night. I mean, their 2 kids are doctors. They didn't even call us. They just went to the hospital. And whether or not that was necessary, I think you see that a lot in our patients is, well, I could call the surgery clinic, but if I don't get someone right away, I'm heading to the ER. We're trying to build something where we can support where those holes are, symptom management in the middle of the night. And if they need to go into the ER, they do. We're not there to stop all of this, but when we look at the scope of all the care Methodist provides, how much care that shows up in the ER could have been averted with more support at home. I think the ER docs would say, yeah, quite a bit. And the hospitalist who the ER calls at 3 in the morning and says, we need to admit this person. We don't have any other good plan. They live alone at home. They're elderly. Their family doesn't think they're safe. I can't just push them out on the street. We'll admit them observation until we come up with a better plan. Maybe that could have been headed off with more support. I think that's the best way I can answer that question. I think for you guys, I don't know, sometime with all the physicians, I'd love to sit down and talk about what numbers do we want some help with. My guess is, for you guys, probably surgery outcomes are probably something that is monitored and you watch, and trying to decide which patients, there are going to be patients who demand or want surgery. I had a call from a urologist a couple of weeks ago who says, I need your help. I have this elderly gentleman in the hospital who is demanding that I do surgery, but he's going to die if I do surgery. I cannot convince this guy it's unsafe. There's these patients where they really want surgery and you guys may not think it's appropriate. How do we manage this? Or there may be people that we want to do surgery on, and another set of eyes looking at the patient saying, whoa, can we pump the brakes? I'm really worried about this patient for these reasons. Can we have a talk with the whole team to say, is it appropriate? I think most surgeons that have anything tracked will say that's the hard part, is these really iffy patients. It feels appropriate to do surgery on them. Their outcome is poor, hurts us. Was there something that we missed on the front end? Was this the right thing to do or not? I'm not saying, I'm not a surgeon. I'm not going to come in there and say this is why I think. But just having another set of eyes to communicate with patients and families and find out where they're at. We can help in a lot of different ways, and communication is a big piece of what we do. I was up with a patient who was talking to an oncologist, and I asked if I could kind of be there so I could hear exactly what the family heard, and I noticed that it was all way above the family's head. My dad was very hard of hearing, so I'm used to the polite look at you in your eyes and nod, yes, I understand what you're saying face, and they had that the whole time. And then later I came back to talk to them, and they shared right away that they didn't understand a thing that the oncologist said. And I was able to try to figure out how to translate to them what was going on. And I think they found that really helpful. And we don't do it on purpose. My first lecture as a fellow I gave to the med students at University of San Diego, UCSD, University of California, San Diego. And I started talking, and I brought up MET. And this hand shoots up in the middle of the room. I said, yes? And he goes, what's a MET? They were first-year med students. It didn't even occur to me that I couldn't use some lingo that they didn't understand. So any service, I think the gyn-onc service, I think you guys, there's a couple of services that have sort of seemed interested in working closer with us. I think part of that working closer together is building a relationship and a familiarity with each other, and also figuring out how can we be most helpful is what we'd like to do. Again, we're not going into any of these with an agenda. And if you say, hey, we need help managing delirium post-op, or we need help with X, Y, or Z, or we'd love families to hear. I've had a decision maker for this elderly woman. The hospitalist was recommending hospice, and this decision maker was a neighbor friend of this elderly woman. And I simply called and said, hey, I just wanted to introduce myself. I just wanted to let you know that I think the hospitalist and the plan that they have in place is absolutely 100% the right move. He said, it's just good to hear it from two people. He's like, yeah, I trust that first doctor, but there's always in the back of your head, like, what if I had a different hospitalist today? Would they have had the same opinion? He said, just hearing from two people that I'm making the right decision for her, just put him at ease. So.
Question. Is palliative care consults started with the initial diagnosis here at the cancer center?
I would say not yet. Again, I think there's a couple of the cancer services that have shown an interest in working with us most, and I think as our capacity, I would say there's a little bit of a numbers problem. I don't know that we have the staffing yet to quite do that, but if I go to administration and say, hey, the gyn-onc or the head and neck doctors are kind of looking for this support, this is what I think it would take to do it, can we get some growth, I think that's going to help be able to meet that need. I think you're going to see, like I said, around the country, palliative care is just going to be embedded in all cancer services, and there's going to be somebody there all the time that meets people always at the first visit, I think is what you're going to see. Good question.
Is that part of do you know if that's part of I apologize because I don't know all of the routine of the cancer center, but as the disease progress, and the intent from curative to palliative, obviously you probably are brought in at that point in time, or hopefully you're brought in sooner for that introduction to help with those.
Yeah, the problem is there's some guidelines. I'm trying to think of which one it was. Some of the transplant guidelines that are coming out now will say that in order to be an accredited whatever, you need to have palliative care available or involved with no more definition. So places say, hey, we have a monthly meeting. Can somebody from palliative care come sit at that meeting for an hour so we can check that box that you are involved? I would say yes, but I think that guideline was striving for more. I think it was striving for the really integrated, available. But oftentimes, it's such a new thing and the language is so vague. We're getting services saying, hey, I need to check this box on my program. Oh, oncology, the fellowship at the Med Center needs to have a hospice and palliative care exposure. And I would say what they're exposing their fellows to is not in the spirit of what they were supposed to be. It feels like very much like a checkbox thing. So again, with growth, I think you're going to see this embraced more and available more. It's just a matter of, I'm a fairly impatient person, and so I want to see this growth happen quickly. So.
Another thing is, I think it's more patient education as far as that goes. For them, they get scared, their anxiety goes up in the middle of the night, their pain escalates. What do? But they end up in the emergency room.
Yep.
So having that plan ahead of time so that they know what to do, who to contact if things start to spiral out.
What? Yep. There's a lot of people who leave the hospital. They're not quite ready for hospice. And to be honest, I can't prove they have a prognosis of less than 6 months. They have dementia. I mean, it could be a month or 3 years. I really don't know. And the family's not quite ready for hospice. We've talked about it. They kind of want their loved one not to come back to the hospital anymore. They want them to. But the nursing homes don't have the support they need. If someone's having a problem at a nursing facility, they are looking to get them out of there ASAP. And so they send them to the hospital for, I would argue, one last hospitalization. The patient ends up admitted under observation. We go meet with them the next day and then move them back under hospice to the nursing home and they die the next day. I would love to see a system where we can identify people in the public at a facility and say, you're not arguably hospice appropriate yet, but we really are waiting for the next bump in the road and your family doesn't want us to do much. While you're not technically on hospice yet, when you have that problem, could the nursing home call somebody, the VNA, to come and do a hospice admit and make sure that they're supporting the facility and the family and the patient for end of life and avoid that last 30 hours in the hospital? That's a huge need that I think we could help solve is how do we meet the public's needs before that last hospitalization that no one honestly wanted, but our system has no other route. To expect a nursing home to say, these advanced directives forms that say, I don't want to be rehospitalized, and we check them. It says, I don't want to be hospitalized unless I have symptoms or things that need to be managed in the hospital. Every nursing home on every patient that has a problem is going to say, we can't manage this here, get them out. We will never be able to honor that, leave me at my facility, until we have a system to meet that need. So that's just my 2 cents.
How does immunotherapy with these agents like this, where, that they kind of, I can't say they, because we don't have the data yet to say that they cure these cancers with people with metastatic disease, but they do prolong.
Mm-hmm.
And how do you deal with these new agents and new technologies that come? And, because at hospice,
Yep.
if somebody had metastatic lung cancer, metastatic head and neck cancer, they're going to be dead.
Yep.
And they're appropriate for hospice, but now they get these immuno agents where it's going to be prolonging life.
Right. I generally hate scientists. No, you're right, because the hospice has some very rigid budgetary rules, and it's not even so much their prognosis that is now kind of wishy-washy. It's the cost of these agents, because Medicare says anything you're getting for that disease, the hospice team is responsible for. And a lot of these agents, the hospice teams are going to say, we would love to help this person, but we can't afford to pay for that drug. And we put patients in this, do I get the support at home? I kind of want the support, but this drug is really useful. What do I do here? At some point, I think you're going to see this all get sort of blended. People are going to want palliative care. Palliative care can help you and doesn't have to pay for your drugs like hospice does.
But part of the problem, I think, is the medical oncologists view these drugs as the cure-all that should be in water, and then we're all forever because of therapy agents. And so I don't think, what I've been noticing is that patients a lot of times are not being informed properly of their disease status.
Yep.
It's still uncurable disease. It's still
Yep.
metastatic
Yep.
disease. We have different agents. We have different targets to go for, but it's still uncurable
Yeah.
disease.
Yeah, and I think a lot of these people are going to be resistant because of what they're doing and what their doctors are telling them to consider hospice. I still think that they potentially have needs, and as they decline, how can we meet their needs without technically calling it hospice so that we have all those funding issues? I think you're going to see palliative care programs that are going to be caring for more and more people like they're on hospice, trying to prepare the family so that when we get to the point where the family says, oh, he literally can't take this med anymore or whatever, then we can flip the switch and call it hospice. And we're going to have to solve this because it's a lot murkier with some of these treatments than it's ever been. And that's hard.
That's where I think some of the language comes into it too. When you read some of the medical oncologist notes, they talk to the family about it being treatable but not curable. But I think what patients and families hear is, oh, it's treatable, so that gets murky in
Yep.
terms of what they're hearing from their oncologist.
Yeah, and if you have 10 different oncologists in this hospital talking to 10 different families, communication is an issue and the words that we use. And one family you go in and they have been prepared amazingly and they understand things amazingly. Next family doesn't, you talk to the oncologist who believes they've said this to the family and you go in and hear what the family heard and it's, wow, it's amazing how difficult this can be. And that's why we have a job, is helping through some of these really hard situations. But yeah, the water's getting muddy, and we've got to, as a system, figure out, is hospice the right thing? What is hospice's role? How can palliative care help? Again, the issue primarily is that for the most part, palliative care isn't funded. Other than my time with the patient and my doctor visit, unlike most physicians who bill based on what they do because you can bill more and more quickly, we bill primarily on the time we spend with families because we spend so much time. And you can't keep your head above water if you bill just on your time. And that's where we need the support of the administration and the system. We need their support to stay afloat. I think and I hope that everyone appreciates our help and our care and thinks that it's worthwhile.
So something that I've noticed with a lot of head and neck cancer patients that I work with is that not only are you battling some of the symptom mitigation for those patients, but you're also recognizing that they are undergoing a total identity overhaul with problems with a physical change. Sometimes they can't go to work, and that may be something that they saw a lot of self-worth, and intimacy issues, like all of those different. They have a total overhaul of some of their psychological well-being. Do you train in how to manage those kinds of things as well?
So what I would argue is that hospice and palliative care is viewed as holistic care. And part of the reason is that we are supposed to have a team of people as part of our team so hospice is required by Medicare to have bereavement, chaplains, volunteers, home health aides, nurses, PT, OT, nutrition. It's got to be a team of people to meet whatever needs each patient has. Palliative care should ideally be built in that same model eventually. The problem is, when you go to administration and say, I need these 9 specialists as part of our team, here's the bill, they say, whoa. We're at the stage where we've got clinicians, the nurse practitioners and the docs. We're just started getting some RNs. We work closely with social work and chaplains. We don't pay their salary, though, they're not part of our team, but we try to work closely with them. So in the inpatient realm, we're trying to put all those pieces together because it's all here in the hospital. We can just use it. Outpatient and clinic-wise, someday I'd love to say we have a psychologist on service. We have all of this as part of our team. We're not there yet. So at this point, if we had really identified something, we would maybe send them to Kevin, or we would try to find them that resource. But I would argue right now, it's not all specifically under our umbrella. As part of the Cancer Center, we would try to get people to the right resources. But if you look at super mature programs on the coast, everything meets in the middle. I used to get my t-shirts from my cousin in Seattle when I was in junior high because in 2 years they would be cool in Minnesota. Everything starts on the coast and ends up in the middle. So the mature, I bet you if you asked Mount Sinai in New York, they would say, oh, part of our team is this. They probably have this very large, big, mature program. Yeah. Yeah. So we are sort of in our infancy, and if that's a need, I agree with you. That's probably a huge need, specifically in your population. That's something, if we're going to be working closely with you, we may be eventually kind of plugging some of this more specifically into it. That would be, and for your population, that might be a real gem for us to say, like, hey, we do this. The problem is trying to get the resources to be able to do that. Good question.
Give a plug for social work on that, because those are all issues that we work with, and if we can't handle it here at the Cancer Center, we refer people out to so many head and neck patients or outside Omaha. But I don't get a ton of referrals on those issues. So.
Yeah. And maybe it's a matter of all of us, sort of recognizing it and feeling like, shoot, there's not a lot to do about it. Right now, hearing that there's resources, perhaps we identify things more and try to pass them on more. And then if we can show that there's a need, that's the best way to sell it to administration is, hey, social workers are overwhelmed with this piece of their practice, and how can we all do this better together? So, well, I want to be cognizant of your time, since I wasn't when we started. I'm so sorry. Okay, all right. Thank you all.